I think we're going to conclude the session with speaking about pharmacology, and it's my pleasure to introduce Dr. Ibrahim Hammasani. He's a clinical pharmacist, and now he's going to focus on the medical or medication in hypertension. So please share with welcoming Dr. Ibrahim.
Good morning. Assalamu alaikum, everybody. My talk will be just a quick summary and a very short talk. It's only 20 minutes. So we'll try to make this, majority of the things is just a summary and repetition of what have been said this morning. So inshallah, we'll get going. So the important thing really, you have hypertensive patients. These patients need to be seen frequently until they really reach their target or close to their target. So every 1 to 2 months, the patient are relatively stable. However, patients with very high blood pressure, they need to be seen more frequently in the clinics. Once patients really approaches their target level, and you've heard a lot about targets this morning, slightly confusing. However, there are two magic numbers, 140 over, less than 140 over 19, less than 130 over 80. Both of them are good. It depends on your patient population, depends on risk factor and cardiovascular risk factors. So once patient is stable and they're close to their target, then really you can see them, then you can see them every 3 to 6 months in the clinic. This is a quick intro. Why is this not? Okay. Now, why treat the blood pressure? Several randomized control studies and many meta-analyses really of those studies have shown that treatment of hypertension will decrease all major cardiovascular events by 20%, and all-cause mortality by 10 to 15%, and coronary events by 20%, and heart failure by 40%. So you leave your patient alone, patient is treated but not controlled, then you end up with these major complications, or one of them. It's not working. Oh, turn back. Sorry. Okay. Now, really, treatment is very simple. Use any drug, any combination from those 5 groups or classes to treat hypertension. In the past, we used to say, well, use diuretics first, use this first, use that first, and so on. Evidence, and many evidences, randomized controlled studies, meta-analysis have shown these are the first-line 5 classes of medication. Then you can pick and choose. Obviously, there's certain situations where you have to fine-tune it and really zoom in on some specific agents. However, thiazide diuretics, ACE inhibitors, ARBs, and long-acting calcium channel blocker, dihydropyridine calcium channel blocker, and beta blockers at the bottom. So Dr. Abdul Hamid said 4, but I really agree, both the European and even the American now, they emphasize also the importance of beta blockers in patients who are less than 60 years of age, and we'll talk later why younger than 60. Usually combination of 2 to 3 first-line agents should be considered if systolic blood pressure is more than 20 millimeter of mercury above target or 10 of diastolic above target. The use of single pill combination where ACE and ARB is combined with calcium channel blocker or diuretic significantly enhances drug compliance and results in better achievement of blood pressure target. So monotherapy is more or less restricted to the perhaps high-risk patients with the high normal blood pressure like 130 to 139 or grade 1, 140 to 159. Perhaps you can try with monotherapy, just single agent, but majority of time you'll need at least 2 agents, if not 3. Hyperkalemia should be avoided all the time. Now let me try this again. Can we have the next slide, please? This doesn't seem to be always working. Now, randomized control studies again described a trend now. Why beta blockers? I put number 5 at the bottom of the 5 classes. Many studies have indicated that the beta blockers have got less favorable outcome on stroke prevention. And as you know, stroke is a major complication of hypertension. And also, they have less favorable outcome on the regression of left ventricular hypertrophy. So this is why the role of beta blockers is in and out, but it depends on risk factor that your patient really is having. So beta blockers directly and partially, their combination as well, may predispose patient for increased risk of diabetes. And this is why we say less than 60, the risk is perhaps less, but as we age and so on, and insulin resistance and dietary habits, then the risk of diabetes becomes really higher in those patients. Combination of ACE and ARBs is really more or less contraindicated these days because of decrease on renal function and GFR. ACE and ARBs are potential teratogens to avoid in pregnancy, and particularly in females with childbearing age. Hypertension in association with diabetes. I'll provide a summary at the end of this, and really I adopted this summary from the European Society of Hypertension and Cardiology, which is very simple. So really in diabetes, ACE and ARBs are really renoprotective, and they're excellent agents to use. Addition of calcium channel blocker is preferred over diuretics here. Reason diabetics really may interfere with the glucose control and may cause glucose intolerance. Addition of a loop diuretic is important if CKD is on board. Now, the hypertension association with cardiovascular diseases. In coronary artery disease, so ACE inhibitors or ARBs, beta blockers, long-acting calcium channel blockers are really the first-line agents. In stable angina, beta blockers or calcium channel may be used as initial treatment. When combination therapy is being used for high-risk hypertensive patients, ACE inhibitors with dihydropyridine is preferred, calcium channel blocker is preferred over combination with thiazide diuretics in coronary artery disease. Avoid short-acting nifedipine. Nobody should be using short-acting calcium channel blocker these days because of the risk of severe hypotension and perhaps coronary syndrome and ischemic attacks. So only long-acting calcium channel blockers are really recommended, and short-acting nifedipine has been really deleted from many hospital formularies. Combination of ACE and ARBs are contraindicated again, and be careful when really in coronary artery disease. Be careful when you're really lowering the blood pressure, not to lower it, not to lower it too much. You know, the diastolic blood pressure not to drop below 60, and then you create a problem with cardiac perfusion. Oops, we skipped one. Oops. Okay. So recent myocardial infarction. Here, the role of beta blockers is really very important. ACE inhibitors as well on top of that. ARBs only if ACE is intolerant. Long-acting calcium channel blocker, beta blocker contraindicated. Non-dihydrocalcium channel be used with concomitant. No, non-dihydropyridine calcium channel like verapamil, diltiazem should not be used with heart failure. Now, if we have systolic dysfunction and heart failure, ACE inhibitors, again, always number one. Beta blockers, for sure, and short, perhaps smaller doses first, and you can titrate as tolerated. ARBs recommended if ACE inhibitors are not tolerated. Now, aldosterone antagonists or mineralocorticoid antagonists really became very important in the control of blood pressure in these patients, and this is about 6-7 years ago when those with having a heart failure class 2 to 4, New York Heart Association, sorry, 2 to 4. I'm trying to use the pointer, it doesn't work. So it really emphasizes the role of spironolactone, particularly in the treatment of heart failure. We continue second-line agents may include sometimes hydralazine and isosorbide only if patients are not really controlled with the first-line agents, which is ACE inhibitors and calcium channel blockers. So hydralazine and isosorbide could be used only in heart failure. Dihydropyridine, calcium channel can also be used. ACE and ARB combination here only in heart failure could have been tried, There's still an option, but really the risk of having increased serum creatinine and perhaps decrease in GFR is very risky. Thiazide like that or loop diuretics are recommended as additive therapy in all heart failure conditions. Left ventricular hypertrophy, ACE inhibitors number 1, ARBs if not tolerated, long-acting calcium channel blockers or thiazide like diuretic. Direct arterial vasodilators, hydrogen monoxide here are not to be used and are contraindicated. Now post-stroke or TIA. Stroke is a big problem. What you need to do, you need to really lower the blood pressure very gradually and very slowly. And really a reduction of approximately 15 to 25% in the first 24 hours is very reasonable. But you also need to involve a neurologist here and a specialist because really it's very critical. You don't want to compromise circulation to the brain. Oops. So non-diabetic CKD, chronic kidney disease, ACE and ARB, of course. However, combination with diuretics and other agents may be used. Careful monitoring of renal function and potassium. One of the major problems with ACE and ARB, perhaps decrease in serum creatinine and decreased perfusion to the kidney. This may occur within the first 2 to 5 days, but up to 3 weeks of treatment. Now, as much as 30% increase in serum creatinine could be expected. More than 30% increase in serum creatinine is not accepted, and perhaps here a change in therapy will be really needed. However, from my experience and a lot of your big practitioners, majority of patients will have a slight increase in serum creatinine, like perhaps in the 5-10% ratio, and not more than that. In renal vascular disease, remember, if you have bilateral renal artery stenosis, then the use of ACE and ARBs is contraindicated because of the failure, because of risk of renal failure. So this is something, if you have unilateral, then it's not really a problem. Major complication. Now, I should really say here, if you've noticed in one of the first slides, I put diuretic on top of the list. Cost of the medication seems to be one of the major important factors in treatment and patient compliance for hypertension. In the Middle East, majority of patients do not have a free national health coverage. Big proportion of our patient population cannot afford the medications. They pay out of their own pockets. Now, guess what? Diuretics still very cheap. The old generation ACE inhibitors are very cheap. Some calcium channel blockers are cheaper than others. Some older generation beta blockers are cheaper. Now, the message is use any medication to control blood pressure. So guess what? If a patient doesn't have any coverage and cannot afford to buy the expensive agent, then I believe you can really stick to any of the 5 classes that we mentioned initially, provided the patient can afford the treatment and he gets and really complies with your prescription. Otherwise, you cannot control the blood pressure. Now, another thing that you need to keep in mind, some of the major side effects of the antihypertensive agents. Thiazide diuretics are contraindicated in gout and hyperuricemia. They're also possibly contraindicated in the male gender, for example, if they are young males because of sexual dysfunction. They may become a metabolic syndrome. Glucose intolerance is something in pregnancy. They may cause hypercalcemia and hypokalemia. However, the compelling contraindication is really gout. And perhaps diabetes is another thing. This is not compelling, but possible. The beta blockers in real asthmatic patients and COPDs, or high-grade or sinoarterial or arteriovascular, if you have a heart block, or bradycardias, then beta blockers are very problematic. But again, a lot of them may cause also male sexual dysfunction, or they cause a lot of sedation in patients receiving them, at least initially. They also cause glucose intolerance and hyperlipidemia, both for thiazide diuretics and beta blockers. Not all of them, but selected beta blockers may cause hyperlipidemia. Calcium channel blockers, usually the local edema or peripheral edema, lower limb edema, could be a problem. They may also really heart failure, class 3 to 4 is possible. and pre-existing leg edema. Tachyarrhythmia is another good reflex tachycardia. Calcium channel blockers, the non-dihydropyridine, verapamil and diltiazem, really they're not being very used these days for just the control of blood pressure unless you have to. ACE inhibitors contraindicated in pregnancy and the women of childbearing age if they're really still planning to get pregnant. This is something, but they are common in pregnancy. Previous angioneurotic edema, hyperkalemia, cough with ACE inhibitors is very common, and bilateral renal artery stenosis. ARBs, more or less the same thing, but they don't really cause any cough. So they could be an alternative in a lot of situations. Oops. Now, single pill combination has really, many studies have shown that the single pill combination is much more effective in controlling blood pressure because it helps really patients to comply with their treatment, with the treatment. You give one pill containing 2 or 3 medications for the whole day, and this is wonderful. The problem with this is the cost, and this is what I said. You want to treat the patient, or you want to give a patient a very costly medication that he will not buy. So really compliance here and patient financial situation should be taken. However, Europe, Canada, perhaps part of the UK, part of the US, this may not be a very big problem. In the Middle East, this remains a problem, patients affording the medications. And the list of all these medications and the combination, everything are available. So the FDA webpage, and you look under drug list, and you will really, drug search list, and you will really find the list and the cost as well. Am I running out of time? Yeah? Right. So I talk about single pill combination. Other antihypertensive, all the other agents, they have specific indication. Centrally acting, like clonidine, is very famous. Patients not responding. We more or less use it mainly in hospitals. When we discharge patients, it causes severe postural hypotension and risk for fracture and fall. Alpha blockers, if you have patients with BPH, non-dihydropyridine calcium channel blockers, they have specific indications. Vasodilators, we talk about them, heart failure, and mineralocorticoid like spironolactone is an excellent add-on medication these days to control uncontrolled blood pressure. The summary now, only allow me with this. I have 3 slides, and really I adopted this completely from the European, and really the European guidelines are excellent, very detailed, and very simple, and perhaps the clearest. Don't forget really the Saudi SHMS guidelines are excellent, to be honest. But these just came recently and did a bit of differences, really, and they're very well structured. If you really quickly look at this, ACE or ARB and calcium channel blocker, plus or minus, diuretic are there most of the times, and that's spironolactone. Very simple. Again, you have cardiac here. Same thing, ACE or ARB, beta blocker or calcium channel blocker, and you throw in a diuretic here. Oops. And finally, last slide. It's not going back. Thank you very much. Oh, it went back, but it's a bit too late. Thank you very much.